morning, everybody. We are so excited to be here. I am Denise Diamond from the Center of Excellence for Health, and we are here in the beautiful lab at NBCC in the Respiratory Therapy Simulation Lab. We have a beautiful class. That's our host class today, Ms. Cochran's class. If you guys can turn your camera on and wave, that would be lovely. Are they waving? No.
Wait, here they come.
Yeah, it's so lovely to see students here, and I do think that you're in for a treat. Certainly, we are going to ask that you hold your questions to the end, but we have some beautiful people here. We have some NBC students here that are showcasing their new skills that they've learned here in the program, and you're going to be able to see all kinds of really cool things here in the lab. So the Center of Excellence for Health provides these opportunities so that we can really help showcase what's happening in our province, but also expose students to different careers that maybe you haven't thought about. And respiratory therapy is definitely something that I'm very interested in, just because I have this job and I get to travel here and see the lab, talk to the instructors, talk to the students, and maybe if we have time, some of the students will speak about why they're here today. So without further ado, we have our very beautiful guest, Carolyn McCoy, is the Director of Accreditation and Professional Practice Services from the Canadian Society of Respiratory Therapists and NBCC Respiratory Therapy faculty and senior students to explore the dynamic profession of respiratory therapy. So I'm not going to take much time to introduce everybody. Carolyn's going to be on. This is her show, so have fun.
Hi, everyone. I'm just going to hit the stopwatch because I promised I'd only speak for about 4 or 5 minutes so we can get to these scenarios. So, Deneen, thank you for the introduction. I have been a respiratory therapist longer than you have all been alive, potentially longer than your teacher has been alive. And what that means is I've really got to see the profession grow a lot in the almost 30 years that I've been an RT. I trained at NBCC St. John, New Brunswick. I taught at NBCC St. John, New Brunswick. I worked at St. John Regional Hospital, and for the last 10 years, I've been with the Canadian Society of Respiratory Therapists, where I work with RTs to help with practice-related issues. Super big thank you for being here today. This is actually our National Respiratory Therapy Week. This is a week that we take some time to recognize the amazing work the 12,000 RTs are doing across Canada and to help people understand what it is they do. So I'm really happy to be here just to give you a real high-level description of what an RT does or what RTs do across the country. After I speak, we have 3 students with us, Laura, Jesse, and Tristan, and they're going to take us through some scenarios. One nice thing about this respiratory therapy program is they use high-fidelity simulators to get you ready for clinical practice. What that means is before you actually practice on a live patient, you're going to hone your skills here in this lab. You're going to make your mistakes, you're going to learn, you're going to learn with, from, and about each other, and you're going to be ready to go the first time you walk in the door of the hospital. So what do RTs do? RTs work in every part of healthcare. Quite often we see RTs as being a hospital-based job, and that's really where we got our beginning. Was after the war, we started working in the ORs and bringing oxygen cylinders around. But our profession tends to attract people who like change, who aren't afraid to try new things, who build new equipment when they need it. And that allowed our profession to evolve into the ICUs and into all the different areas where we work now. So in the hospital right now, respiratory therapists are working in the operating rooms where they're physician extenders, which means they're supporting the anesthesiologists who can now leave the room and go take a break or go to the washroom while the RT takes care of the patient. They're working in intensive care units, and that's where we got a lot of publicity and exposure during COVID because respiratory therapists were running the ventilators. They were also advising the governments at every level about what needed to be done to prepare for this pandemic and manage the pandemic. So it was really neat to see RTs at the table with governments and decision makers. Respiratory therapists are also working to take patients from ICU into other parts of the hospital. So as they improve, they migrate to another part, or the reverse can be true. They can be in wards and need to go into ICU, and RTs are caring for them on the wards as well, where they're providing oxygen therapy, drug therapy, doing a lot of patient education, and working with other members of the healthcare team. RTs also do diagnostics, and sometimes that means they're working in a hospital-based diagnostics lab doing breathing tests. But other times it means they're out in the community where they really are truly the expert in getting the best possible test from the patients so that we know what's going on with their lungs and we can figure out the best treatment for them, with them, and the other members of their team. Respiratory therapy has left the walls of the hospital, and that's super exciting for our profession. And New Brunswick is actually a leader in that respect. We have this incredible extramural program in New Brunswick, which means we're caring for patients outside of the walls of the hospital, and RTs are fundamental parts of those teams. That means they go into patients' homes, whether that be their home in a subdivision, in an apartment, in a special care home, in a nursing home, in hospice, and they provide hospital level care, hospital caliber care in the patient's home. And that does mean mechanical ventilation in some cases, where RTs take that expertise that they traditionally learned in the hospital and now are applying it in another setting. RTs are working in clinics and physicians' offices more and more. What we're seeing as the governments look to restructure and fix primary health care, respiratory therapists and other allied health professionals are being brought into these physician teams to care for patients at the front line. And RTs are working in hospitals and universities, colleges and universities where they're teaching and they're doing research. Some are working in sales, some are working in sleep diagnostics. There's such a vast array of where RTs work that I'd be lying if I said I can describe the typical day of an RT, because there is no typical day for an RT. If you work in the hospital, you're not going to see 2 patients that are the same, but you're likely going to see 30, 40, or 50 patients in the run of your shift. And if you're in ICU, you're going to see a fewer number of patients for a longer period of time. But if you're in the wards, you're going to see a large number of patients for a shorter period of time. And the other people on your team are always going to change. You're always going to work with different doctors, nurses, physios, nurse practitioners, dietitians, and you're part of that great big connected team providing care for your patients. It can be a stressful job though. You are dealing with some of the smallest patients you'll ever see. The smallest patient I ever worked on was born at 1 pound. And actually, thanks. This is one of the mannequins you'll use as a learner here. This is bigger than the smallest baby I ever cared for. RTs help these babies take their first breath. You also work with kids and adults. You work with people at every stage of life. You help with the first breath, and you help make the last breaths more comfortable and easier. It can be a stressful job when you do that. Healthcare is finally recognizing and catching up to that and realizing that stress is part of the job and helping people maintain and manage that. So you do hear about that in the news, particularly during the pandemic. Healthcare is stressful, but we're finally catching up to make sure that the care our caregivers need is there. Now, you don't want to hear from me. You want to see what an RT does. And again, this is not a typical day for an RT, but we're going to show some scenarios that are common for RTs to see in the hospital setting. And I do want to send a huge thank you to our 3 students who are in their clinical year. We'll talk with them in a little bit, with Jesse and Laura and Tristan. They're going to talk to you a little bit about their training and education. We have John Doucette, a faculty member here, who will talk to you about what does it take to become an RT. First, we're going to look at this gentleman over here. He's not doing very well. 63 years old. He's a smoker. He has something called COPD, which is a bit like emphysema and asthma combined. And he has had a really nasty pneumonia that's required him to be put on life support or on a ventilator. And you know what? I hear them calling a code right now. We're going to watch and see what they do to help this patient. No problem. Can we have the bulb in here?
What's happening, Jenny? Okay, let's get some defense hats on them, and when you're ready, we'll shock them at 200 joules, please. Keep going with CPR. You guys are doing great.
Urging.
Great compression, Laura. Keep it up.
Talking.
Okay, get back on the chest. We're going to do 2 minutes of uninterrupted CPR. Jesse, if you have a chance, could you push 1 milligram of epinephrine, please, and let me know when that's been done. How's ventilation, Tristan?
Ventilation's good.
All right. Keep it up. Great compressions. Thank you very much, Laura. So we'll do this for another minute and 30 seconds, and at the end, we'll do another rhythm check. See if we're still in the shockable rhythm. Thank you very much. And repeat that every 3 minutes, Jesse. Jesse, could you palpate his femoral pulse to make sure we're getting a good corresponding pulse?
Good.
Excellent. In 1 minute, folks, we'll do a rhythm check. 1 minute. During the rhythm check, Laura, Tristan, I'll get you folks to switch roles. And Jesse, if we're still in a shockable rhythm, I'll get you to defibrillate him at 300 joules, please. Great compressions. Keep it up, Laura. Rhythm check in 30 seconds, folks. Coming up on 15 seconds, Jesse, could you pre-charge the defibrillator for 300 joules? And if we need it, we'll be ready to go at rhythm check. 10 seconds, folks. All right, let's do a rhythm check. It looks like we have an organized rhythm. Do we have pulses? We have pulses?
Yep.
Excellent. All right, let's get him back on the ventilator, folks. Jesse, could you grab a blood pressure for me? Great work, folks. Excellent work. Whenever you get a chance, Jesse, I'll get you to grab Chem 7, cardiac enzymes, and some CBC. Laura, could you get the workbook to order a chest X-ray and a 12 lead ECG, please? Thank you. And when you get a chance, Kristen, can you grab a blood gas and let me know what the results are like? How long we're gonna have to wait before we grab a gas? What do you think? 20 minutes? Okay. If you think you need to make changes on the ventilator, just make those changes. Let me know. All right, team. Thanks a lot. I'm gonna go finish my coffee.
So nothing like you've seen on ER, hey? Because guess what? Medical shows don't know what they're talking about. They need RTs on their writing team. So, Jesse, Tristan, Laura, can you talk a little bit about what your roles were during this resuscitation? Because you guys were really doing what RTs do.
I was doing compressions, which helps pump the blood around the patient. Tristan was managing the airway, which helps oxygenate the blood during compression. And Jesse was pushing epinephrine and managing the defibrillator to shock the patient.
Excellent. So we saw you use the ventilator a little bit. We saw you with the defibrillator, with the monitor. What kind of equipment are you using in a typical day in an intensive care unit setting? Because ventilators are only really used in intensive care when they're this kind of ventilator.
Yeah, so we use ventilators, we use portable ultrasound machines, portable x-ray machines, we use defibrillator machines as well. We use bronchoscopies, direct video laryngoscope to help intubate patients.
Excellent. So a lot of those are things that you're going to use to help diagnose and see what's going on during a situation, as well as support the patient's heart and lungs when they're in ICU. Excellent. All right. Can you tell me a little bit about, I guess actually we covered those questions. I'm sorry. So our patient's getting better. He has now gotten off the ventilator because the RTs have worked with him and with the other members of the healthcare team to reduce the amount of support that he needs as he got better. And there's a real art to that. And RTs are phenomenal and they're experts at doing that. Now, he's probably going to leave ICU in a few days and go to the wards or the floors of the hospital. So not an intensive care area, but an area where he's still requiring additional assistance and therapy. So let's check in and see how he's doing now.
Tristan, I hear you're going home soon. That's good news. So we won't have to keep you on this very big oxygen anymore. We're gonna be able to take that off you for a little bit. I'm gonna have to take a blood sample from your artery right here. Okay? Let me get this off of you, and then we'll have to wait 20 minutes before we can take your blood sample. I'm just gonna go gather my supplies, and then when I'm back, we'll do your blood sample, okay? So take this blood sample. It's going to be from your artery right here and not your vein. You might feel a little bit more of a poke than you normally would with regular blood work. I'm going to clean the area with some alcohol. Okay, I'm just feeling for your pulse now, okay? You're going to feel a little bit of a poke. Awesome job. Well done. You did great. We're going to send that down to the lab, and then that will tell us if you qualify for home oxygen or not. Then we're going to set you back up on just a regular nasal cannula this time. And this is what you would have at home when you go home. You have small ears. Here, so we'll wait for your blood work to come back, and we'll see if you qualify for home oxygen or not, okay? And they've also decided that you need some puffers at home. So we have these 3 puffers that you'll take at home, and you'll also be using this device with these first 2. So when I come back later to tell you the results of your blood gas, we'll kind of go over these a bit more and you can show me how to use them, okay? Alrighty, I'll see you later.
So we saw Mr. Smith on a few different oxygen devices, a few of their large range. Can you talk a little bit about why you were using different types of oxygen therapy devices with Mr. Smith?
Yeah, so when he first got here, obviously he was on the ventilator, and then we switched him to this one, which we call a high flow device. So it'd be for people who require either a higher flow of oxygen than something like this would give, or a higher oxygen percentage. So based on their illness, they'll need more oxygen percentage than say like other patients.
And you'll assess them to figure out exactly how much they need.
Yeah, so we look at like their vital signs, their oxygen saturation, and their blood gas levels to kind of see what they need.
Okay, and a blood gas, that's what you were just taking from his artery. You said you took it from an artery. Why are RTs taking blood gases from arteries as opposed to taking blood from veins?
So when you take it from the artery, it gives us their oxygenation status, whereas from a vein, it wouldn't as well. So we can further tell the oxygenation status of the patient.
Yeah, and is it RTs, nurses, doctors? Like who typically does blood gas work in the hospital like that?
We are normally the ones that do blood gases. In the ICU, they also have things called art lines. So it's like the same thing that we did, but it's always there. So we can just draw it the same way.
Excellent. Now you mentioned that Mr. Smith might go home on oxygen therapy. What's the RT's role when someone goes home on oxygen?
Yeah, so we start in the hospital and we do the blood gas like we did. There's certain criteria that patients have to meet to qualify for home oxygen. And then when they're at home, we have an extramural program in Brunswick, and there's an extramural RT who will go and see the patient and assess them and make sure their equipment's working correctly and just make sure everything is functioning the way that it should.
Great, and then they do the follow-up assessments to see if those levels need to change or anything.
Yeah.
Excellent. Well, Mr. Smith, I hope you have a safe trip home. I know you're in good hands with your respiratory therapists. Now, I mentioned that RTs look after babies or patients of all sizes and all stages. It's really hard for some babies to take their first breaths, whether they're born premature or at term. Quite often, babies need a little bit of extra help. Sometimes they need a lot of extra help. We're going to check in on a scenario with the delivery of a baby that's really struggling to take its first breaths. Let's see what the RTs are up to here.
Right now, this baby's not breathing, so I'm breathing for it. But once I notice he starts to take a couple breaths, I'm going to switch him to a less invasive device. So I notice he's starting to breathe on his own. I'm going to switch him to this device. This is for when he's breathing on his own, but he just needs a little bit of support. The flow from this device should help keep his heart rate up and his oxygen good.
Thanks, Jessie. So when you're using this device,
Yeah.
that's actually you're pushing gas into the patient's lungs.
Right, it's called positive pressure ventilation, so it just means you're breathing for the patient.
Okay, and we saw that on the adult as well. Very
Yeah.
close. There was a different side.
Yeah.
Now, this looks a little bit like the device that Mr. Smith was on. Do you use the same devices on different size patients, different levels of patients?
It is the same device, but it's called the OptiFlow Junior, so it's specifically for babies and kids. So it's still a high flow device, but it's just not as high as what adults would need.
And you make that decision based on the patient's size, which
Right.
device you're going to use.
Yeah.
Now, I know a doctor didn't tell you to switch devices. Do RTs often make those decisions as to the best device for the patient based on their needs?
Yeah, you just kind of go by the baby's presentation. So where he wasn't breathing at the start, I was breathing for him. But then once I noticed like he has good heart rate, good oxygenation, and he's breathing on his own, I know I can switch him to a device where it just helps him out with his breaths.
So you used your assessment skills and your clinical knowledge to make those decisions.
Right.
Cool. How often do babies need this kind of help?
Pretty often. I would say the first thing we do when a baby comes out not breathing or struggling to breathe is warm, dry, and stimulate. And usually that's enough, just like rubbing their back is enough to get them to start taking a couple breaths, but less often you have to give them some PPV.
Okay. Now, I know that you gave it this as a resuscitation of sorts. How is a pediatric or a neonatal or a baby resuscitation different than an adult one?
Well, with adults, usually their resuscitation is because of a cardiac arrest. So adults have heart attacks, cardiac disease, stuff like that. So with adults, the most important part of resuscitation is the compressions, keep the blood flowing and the heart pumping. But with babies, they don't have cardiac disease. So usually they stop breathing, which later affects their heart. So their problem comes from the lungs. So the most important part of resuscitation is making sure you're breathing for them so that they can keep their oxygen up.
Okay, so in kids and babies, it's usually a lung problem, and in adults, it's usually a heart problem. So what I'm hearing is when you take CPR and you learn about the CVAs or the CABs, the RT is involved in all of those. Depending on the patient, their level of involvement will vary based on what the problem is. Excellent. Well, good work with this little one.
Thank you.
So I want to bring in the other students now. I want to talk a little bit about what their educational experience has been. To become a respiratory therapist, typically in Canada, you're going to complete a 3-year diploma, or advanced diploma is what they call them in Ontario. But typically it's 3 years of education. Sometimes that's compressed into 2.5. You don't have many weekends or summer vacations, but it's the same amount of knowledge in a shorter period of time. There are a few degree programs in Canada, and you can do degree completion, which was the pathway I took. I did my diploma with NBCC, and then I went to UNB to finish my degree a few years later. All right, I want to talk to you a little bit about the training you've had so far. So you each do different clinical rotations. There are about 18 to 20 of you in the class. Where have you seen, or what rotations have you done so far?
I've only done my ICU so far. And I did a little bit of a small hospital up in Sussex.
Okay, so you started in a rural hospital, and now that you're right into intensive care at the beginning of your clinical year.
Yeah.
Excellent.
So I've completed GT, which is general therapeutics. So it's working in ER, on floors, doing mostly patient assessments and helping with puffers. And I've also done the ICU rotation.
Okay, so again, you jump right in with patients.
Yeah.
So typically with your RT program, you're going to do a lot of classroom stuff first. You might, depending on which program you take, get into the hospital a little bit. That's getting really hard post-COVID because infection control has all been ratcheted up. But this program is unique because right across the parking lot is the St. John Regional Hospital. So you literally go from this building across the parking lot and you're at your clinical site. And as we've seen with these two individuals, you are not thrown in, but you get into those situations really quickly that can be really intense, like intensive care, hence the name. Jessie, where have you been so far?
I've done the OR, pulmonary function testing, and neonatal and pediatrics.
Okay, so again, working in the OR, the anesthesia, pulmonary function is the lung function testing. We didn't really get to see a lot of that today because apparently you have to go to your second class. I apologize. If we could keep you all day, we would, but Mrs. Cochran won't let us. And then you've also worked with kids and babies.
Yeah.
And that's in intensive care as well, or they tend to be in clinic settings?
It's intensive care.
Intensive care. Yeah. So, these are just a sample of the rotations that these students are going to do as part of this program. They're also going to go into the community and work with some of those extramural RTs. They're going to work in the asthma clinic or the sleep disorders clinic. And one nice thing about the program is you're going to see all the areas of practice that respiratory therapists do. And this program is nationally accredited. And what that means is they meet the national standards for education. And that means they have to teach you to work in any part of Canada in any area of practice. And this program has actually received excellence awards for teaching in the past for the work that they do. Okay. What's been your favorite thing so far about your clinical experience?
I love the high intensity situations in the ICU, especially codes. And like codes or in the ER when there's traumas that come in, I like dealing with those.
Sort of those more exciting situations?
Yeah. I'd probably say mine's the same. I really like going to codes, the high stress situations, and working in the ER because you don't really ever know what you're getting. Like every situation's different.
Excellent. Jessie?
I would say like feeling like I'm making a difference has been my favorite thing. And I definitely feel that the most during codes or high stress situations.
Yeah, and I heard an RT say the other day, it's a privilege to be there when someone is taking their last breath or struggling to breathe and to be able to help them with that.
Mm-hmm.
Yeah, absolutely. What's surprised you so far? I'm going to start with Jessie this time.
I would say how intense the program is, like all of the studying, the tests, the book work, it was a lot harder than I expected.
Even though it's community college.
Yeah.
Okay.
I came from university thinking it would be an easy program, but it's definitely harder than university for me.
Quite rigorous.
Yeah.
Okay.
Yeah, I would definitely say the intensity of the program. I wouldn't choose anything else, but it definitely is a lot of work. But if you love it, it doesn't feel like work. And I was also surprised that we could take blood samples.
I'd have to say the intensity of the program. It's very difficult, but it's a lot of fun. And if you enjoy it, you'll really like it.
Yeah, and that's one thing, having toured RT programs across the country, that's true of the 3-year programs, of the 4-year programs, of the 2.5-year programs. It's rigorous no matter what program you take, because you are learning to save someone's life. And there are situations where if you're in a small rural hospital, you might be the person on that night shift with the capacity to save a life. So the workload is definitely there preparing for it. Okay. So you're not being paid to be here. You're here as some community service hours. Can you talk to me a little bit about what those hours involve or why the program makes you do community service hours?
So we had like teaching hours, so we'll help with like the younger years and we'll kind of be involved with them, like teaching them our knowledge. So they get a lot from that. And we also have things that we do like this so that we can spread awareness for our program and work with other professions just so that we can kind of be well-rounded as an RT.
Excellent. And NBCC is actually a leader in the community in terms of giving back. I think you have days every year dedicated to giving back to the community. So I do appreciate you choosing this as some of your hours. I certainly knew nothing about respiratory therapy in high school. And if we can get some interest and tweak some people's passion a little bit, it's really nice that you're here, especially during our week to do that. All right. Well, I'm going to actually bring John in. John's one of the faculty members here, and Liz is behind the camera too. She's at tech support today, and she was running the simulation scenarios. I just want to talk a little bit about what you can expect when you take the respiratory therapy program. John, come on over.
Thank you, Carolyn.
And don't go too far because we may have questions for you from our audience as well. Talk to me a little bit. When someone takes the NBCC respiratory therapy program, what can they expect?
Okay. So first thing, I think what people really need to understand, I think Carolyn alluded to this before, is when she went into the program, and I was the same way, I wasn't really quite sure what to expect in respiratory therapy. I really hadn't heard about it. So I think let's go back to what is the definition of a respiratory therapist? And you are a healthcare professional that specializes in pulmonary medicine. So let me grab that first part. You're a healthcare professional. So whether you decide to study respiratory therapy, nursing, or medicine, there's something very important you have to have: people skills. You need to show empathy. You need to understand when someone is having trouble breathing, why they're having trouble breathing, what they're going through. Compassion. I'm going to tell my patient, I'm going to work hard to alleviate that breathing. And the last one, communication. You have to be able to actively listen to your patients, talk to them, talk to the healthcare team that's working with them to ensure we give them the best possible care. It's first part of the definition. Second part is a specialist in pulmonary medicine. That's the technical skills. We are going to spend the next 3 years of your life showing you all the skills and procedures you need to do to help someone who's having trouble breathing. So like our student said, Tristan, Laura, and Jesse told you, it's intense, but it's very rewarding.
And a small program means your faculty get to know you and they can see when you're struggling. They'll see it on your face and they'll pull you aside and give you the support that you need.
All the time.
Yeah, this program is known for that. So there are those misconceptions about community college.
Yes.
Do you want to talk to us a little bit about, community college versus university?
Excellent. So I came out of university with a degree in biology. So I was a young adult trying to figure out what I'm going to do with this degree. And again, I was accepted into the respiratory therapy program. I wasn't really quite sure what I was getting into, but I decided, you know what? It's community college. Maybe I got this. So I get there. 40% of my class already had degrees. We went out for a beer 1 month. Later, we're all looking at you going, what is going on? How can this be so much harder than university? And here's the thing. I studied wildlife ecology. I can tell you everything you need to know about the mating habits of the eastern coyote. But if I make a mistake, guess what? Nobody gets hurt. Nobody dies. We're learning how to save a baby's life at 3 o'clock in the morning. You and another nurse. So if I decided to blow off that lecture and not go to it, guess what? I'm stuck alone trying to save a baby's life with no skills. So it dawned on me very quickly. What I'm learning is to keep that patient safe and help them out. So I realized very quickly, and I think Jesse and all of the students mentioned the same thing. If you're coming out of a university environment, you realize community college, it's not a joke. Everything you learn is built to something else. Everything I learned was the foundation, what I needed to learn later on. And I'm so glad because it changed the way I studied.
Now we saw some scenarios and we heard from the students today that they like the excitement. Is every minute of the job a heart-pounding adventure?
Okay, as a student, exactly what our 3 students told you. I love the adrenaline rush. I love rushing through the hallway with people looking at me, and I'm running to a medical emergency, stuck in an ambulance with the lights blaring and rushing through traffic. And yeah, I love that part. But there's downtimes, but it's not a downtime. It's time for you to spend quality time with a patient who's not experiencing a medical emergency, like Tristan did with Mr. Smith when she did his blood work. She was going to come back and spend some time with him, showing him how to use his inhalers. That's a big part of the job. Remember, you're not going to score a goal every time you hit the ice with the puck. Okay? A firefighter is not putting out a fire every single minute of the day, but they're there ready to go. The best way I look at respiratory therapists is this. Everyone's heard of physicians, everyone's heard of nurses. Look at them as, if this is the military, they're the regular Army, Navy, and Air Force that the public sees every day. A respiratory therapist is the special forces that come in and deal with the problem, and before you know it, they're gone again. And it was like, who was that? And that's what we do. We come in when you need us there, but we're going to come in behind the scenes and get things under control. That part, I loved it. Who was that guy that just left? I don't know, but he saved my life. So that's a big part of it, and I really enjoyed it. So yeah, you're not putting out a fire every single moment of the day, but you're going to have a lot of time to spend with the patients, and I really enjoyed that quality time. And I go all over the hospital, so I get to find out who's getting the best snacks.
So what was your favorite part of the job when you were still
Oh
working
my
in
gosh.
the
So-
clinical realm?
When I spent 20 years working in the hospitals, now 10 years teaching. And I have to agree with Jesse, Laura, Tristan, I did love the adrenaline rush. 20 years later, after I'm done working with patients, now I'm teaching, you know what? there's one word I think that and no one ever told me this, is that I came to NBCC as a young adult with a degree, not sure what I was going to do. NBCC transformed my life. I became a highly trained respiratory therapist. So I headed out, worked with patients, and I transformed their lives. So the part I loved the most was knowing that I was transforming someone's life. I was helping that baby take their first breath at 3 o'clock in the morning to make sure we could wipe them down, put a little toque on them, swab them, and give them the mum, and tell them that baby took his first breath because myself and another nurse and that whole healthcare team worked together to save their lives. So today, there could be someone studying nursing or medicine or respiratory therapy in another part of the country, and I might have been involved in getting that baby to take their very first breath. So that's the part I love most is transformation. We will transform you, and you will pay it forward, and then you're going to transform someone else's life. And that, to me, you got to feel that, and you'll love it once you get working.
Yeah, it's an absolute privilege to be
It
there.
really is.
And there's
Yeah.
nothing better than to see a patient walk out of the hospital, and then bump into them. If you're from small town New Brunswick and you work in small town New Brunswick, you'll bump into them in the community. And that is a really satisfying feeling to know that person, you hope that life saved that life.
Once at a grocery store, I was waiting in line to pay for my groceries. Someone tapped me on the shoulder. I turned around, and this gentleman I'd never met in my life shook my hand and said, "I know you don't remember me, but you saved my mother's life." Okay, what can I say? You're not going to remember your thousands of patients you'll see, but you know what? They will always remember. You gave them a new lease on life. So that part, you've got to experience it to feel that.
Well, thank you. All right, we're going to open it up to questions from you now. I know you've got a few minutes before it's time to change classes. Feel free to pop questions in the chat, raise your hand, however you want to manage them. John and the students are here. If you have questions about the profession, a great way to find out about it is to Google NBCC.ca and look at their list of programs, or Google us at CSRT, for Canadian Society of Respiratory Therapists.com. If you have specific questions about practice across the country, send me an email, csrt@csrt.com. Happy to answer questions anytime. It's one of my favorite parts of my job is talking to students who are thinking of pursuing RT as a career. So without any further ado, we'll open it up to questions. If you don't ask questions, your teachers might have some work for you to do. So we encourage all the questions you got.
And before we do that, I just want to say that I'm blown away by the passion that we saw today. It's very rare that I find people that are as passionate as I am about my job. And I just saw, I actually had tears in my eyes as John was speaking, and Carolyn and the students were doing the scenarios, and I am blown away by the presentation, but also learning so much about respiratory therapy and the effect that you have on communities and folks and families. So I'm, again, just blown away and want to say thank you right away. But we would love to hear from Ms. Cochran's class. If you guys have a question, I know that Carolyn and her team are really eager and willing to answer questions. I'm not sure if anybody's prepared one, but hopefully through the presentation, somebody has thought about a question. I always have questions, so if you don't have questions, I will come back in.
And I'll mention too, the question we often get asked is, do I have to work a lot of nights and weekends? Yeah, you do, but not every RT does. It depends on where you end up working. If you're working in the hospital, chances are you're going to be working some nights and weekends and some holidays. But there are many jobs in the profession where you're doing the Monday to Friday. And some people love the shift. Some people love the Monday to Friday. The neat thing about RT is there's a niche in there for you. You just have to get the education training and get yourself there.
Awesome. So we'll open up the floor. Ms. Cochran, do you have any questions?
Salary range.
Salary, that's a great question, particularly now, look, we say the only good kind of inflation is breathing, right? But we do have to think about, what you're going to make. It does depend on what province you're in, because cost of living is different from province to province. In New Brunswick, you're going to start at around $25 an hour, a little high. Oh, that's right. You got the salary boost, didn't you? Closer to 30? Okay, you can't see Liz's hand is still going up.
33 to start.
33 to
Yeah.
start.
Yeah.
And in other provinces, that tends to be a little higher. The Maritimes are fairly close, and as you go to different provinces, that will vary. And different provinces have different adjustments. If you work nights or weekends or have students or you take an additional education or have more years experience, that level will vary a little bit. Yeah.
Do any of the students want to come on camera and ask a question? We'd love to have a rock star on the camera.
Oh, I'm sure they would love to do it. I took a whole course in university and it was delivered like this. The professor would start the class, it was organic chemistry, and he'd say, alkanes, which are a chemical compound. McMurray has a wonderful chapter on alkanes. Read it. Any questions, comments, criticisms, queries, or concerns? And if you hadn't read the chapter and didn't have any questions, comments, criticisms, queries, or concerns, that was it for your class. But I know Mrs. Cochran's not the same way, so I'm sure if you don't have questions, she's got some work for you to do.
Oh, we've got a question here from another class. Ms. Singh?
Yes, I have a question. So, as an RT, one would specialize in different parts of treating a patient, right? So, for example, managing with an infant or an adult. So, there are different tasks, right?
Yeah, so that's basically our role, managing different tasks and
Yeah.
age groups. And
Okay, that's a great question. So for anyone that didn't hear it, the question is, what is the RT's role in terms of time management, prioritizing tasks, and dealing with different patients and different ages? That is an art in and of itself. And what happens when you're learning to be an RT is you're going to have progressively more responsibility throughout the year. So by the end of the year, you are going to be able to manage a unit yourself. But what you end up learning is which types of patients do you need to see first, and how often do you need to go back? And that comes a bit with your education and a bit with clinical experience. But even when you start practicing as an RT, I would suggest you probably take another year or so to really get that under your belt so that you know who you need to see when. But the other thing is, remember I said you're part of a team? That means that even though the RT may not be at Mr. Smith's bedside all the time, there are nurses who are there. There are practical nurses, there are PNs, dietitians, physio, OT. Other members of the team are there. And if Mr. Smith needs his RT, the RT is going to be called.
also, just on to that too, there are certain hospitals that only specialize in certain patient populations. So you could just solely be an RT who looks after pediatrics and infants, or you could be in a hospital that has all ranges. So there's the capability to just specialize and be an RT who looks after babies and infants. You could be an RT that just specializes in the OR, or you could be one that looks after all patient age groups.
Yeah, and specializing even within that age group.
Mhm.
There are RTs who are
So my
specialists
students did
in
have another
pediatric
question.
ventilation or pediatric asthma.
Yeah, go ahead, Mrs. Cochran.
They wanted to know what your biggest fear was, or maybe when you first started working, like what was your biggest fear that you had to overcome?
Me, I'll give the students a chance to answer too. I was telling them the story. My last shift as a student was a patient that was really quite difficult and had an emergency occur while they were on the ventilator. And the respiratory therapist and the anesthesiologist and ICU doc said, "You graduate tomorrow. What do you want to do?" And that was one of I'm sure my eyes were huge at that point in time, but I had the support of my team, and that patient ended up going home within about a week. Why don't you come on and let them know what was your scariest moment?
I would say for me, it would be in like second year when we were just starting like the beginning of our clinical rotation, that I wasn't sure what it was going to be like stepping into the hospital clinically. And it was just a lot of unknown, but you're really supported by like the staff RTs, and you're never like feeling like stranded or left on your own. Like they'll always help and teach you. Like, so it's really good in the clinical setting.
I would say that first like initial like stepping into the hospital, you feel like you don't know anything, but you actually do, and putting your like education to clinical practice is a big step. So that was kind of intimidating. Mm-hmm.
Yeah, I would say the same thing, like being able to apply the knowledge I learned practically was probably my biggest worry, but you are very supported and everyone helps you a lot when you're in the hospital, so I'm happy.
Is it a bit like when you study for your learner's permit and you do that textbook studying versus when you actually get behind the wheel for the first time?
Yeah.
Yeah, sort of the same thing. Yeah.
Okay, we'll have the students stay here, and John, come on up. We are just about at the end of our session. I always try to stay on time. Ms. Cochran, thank you so much. Students, thank you so much. If there is any opportunity that maybe we can get you guys here in the lab sometime, we would love to do that as well and give you some hands-on experience with the students and with the beautiful instructors. Carolyn, thank you so much for taking time out of your busy schedule and really appreciate it. Hopefully, the presentation has made you maybe a little bit more curious about RT and what that looks like. You learned about the role, you learned about the impact of the community, and hopefully it just makes you maybe dive a little bit deeper into what you want to do when you grow up. I still don't know what I want to do when I grow up, because there's so many different avenues out there. So please, check out something that you're passionate about. And the girls really spoke about that. They said that, it's an intense program, but if you like what you do, it is not going to feel like work. And that's probably one of my biggest pieces of advice, especially from the Center of Excellence for Health, is to choose something that you're passionate about and go with it, because there's no mistakes with that. With that, thank you so much. Have a beautiful day. And I'll let these folks have the last word.
Well, I just want to thank these folks for having me here today and wish you a wonderful respiratory therapy week. I look forward to being behind the scenes, supporting you for your long careers. And thank you for choosing a profession that I think John, Liz, and I can all say we all really love and are passionate about. And we love having your energy and having you in our ranks.
Absolutely.
Thanks for joining us, folks. Really appreciate it. And please tell your friends.
Have a nice weekend.
See you later.
Thank you.
What?